Hello students, myself Dr. Maddineni Srinivas, your dermatology faculty in Cerebellum Academy. In this video, we are going to see the dermatology previous year questions from NEET 2023. This is the first question. After using a hair dye, a lady developed a skin reaction as shown in the image, and which of the following chemicals among the given options are responsible for this condition? And in the image, what are you able to see? You are able to see that there is erythema which is shown in the hairline, and the chemical is PPD, which is also called as paraphenylene diamine, which is responsible for producing hair dye dermatitis, which is a form of allergic contact dermatitis. So you need to know few points about the ACD. It is basically a type 4 hypersensitivity reaction. There are various chemicals which are associated with producing ACD. So you must know few of them. We are going to see few what are the names of few of these chemicals. So in the metals, remember the jewelry is going to consist of nickel, which can produce this ACD reaction. And in the topical preparations, neomycin, which is an antibiotic, can produce allergic contact dermatitis. And here you are able to see that the newer hair dyes, which are little bit expensive, are being advertised as being PPD free, because PPD is associated with allergic contact dermatitis, which can not only produce this kind of a eczematous picture where you are able to see vesicles and oozing, but also this can produce the facial puffiness. The other chemicals which are important for you to remember are, in the cement we have potassium dichromate, which is also a allergen. And in the bindi, the adhesive consists of PTBP, which is para-tertiary butylphenol, which is also a allergen. So the investigation of choice which we can make use to identify the ACDs patch test, which is going to be giving us two important readings. The first reading we are going to take by asking the patient to come back after 2 days, and the second reading, which is the best reading, is going to be at 4 days after the patch application. Okay, so this is about the ACD. This is the next question. A female presented to the dermatology OPD with acne that is not resolving with oral isotretinoin and antibiotic treatment. So which of the following is the best step out of the following options? So if you look at the image carefully, you can notice that the acne lesions are predominantly present near the jawline, and of course you are able to see that there is also hirsutism in this female. So with all these pointers, clues, buzzwords given in the question, please remember you should think about a acne which is referred to as hormonal acne, and the answer here is going to be to evaluate the possibility of the hyperandrogenism. So remember, if the question mentions antibiotics and oral retinoids were used but the patient is non-responsive, then hormonal acne is the diagnosis which you must think about, and these are all the pointers which can tell you that it is hormonal acne. The insulin resistance, the hirsutism, the irregular menstrual cycles, and the presence of the velvety textured skin over the folds, which is acanthosis nigricans, and the AGA, which is androgenetic alopecia. So in all these conditions, what we should do, we should assess the patient's androgen levels and there are various syndromes associated with the acne. So among which you can see here in the middle we have Saha syndrome, which consists of seborrhea, acne, hirsutism, and androgenetic alopecia. And I hope you all have heard this Hiran syndrome from your gynecology, which is hyperandrogenism, insulin resistance, and acanthosis nigricans. So these are the important syndromes related to the acne, and hormonal acne is one important entity on which off late questions are being asked. So this is very important topic, we can say. The next question is very simple. So young woman presents with the complaints of a painless ulcer in the genital area and it is associated with a non-tender inguinal lymphadenopathy. What is non-tender? It means it is painless inguinal lymphadenopathy. So what is the diagnosis? So please remember, when you get to see a genital ulcer and a inguinal lymphadenopathy, both of which are painless, you must always think about this condition, which is called as syphilis. Syphilis. So answer is option B. So if you look at the other options, chancroid, how does a chancroid manifest? Chancroid is going to manifest with a painful genital ulcer. Painful genital ulcer. And what are the characteristics of the lymphadenopathy? The lymphadenopathy is also painful. Painful lymphadenopathy is present. So, and also you should remember, this lymphadenopathy in chancroid is referred to as bubo. It is referred to as bubo. Now coming to the herpes genitalis, how does it present? Initially there will be grouped vesicles. There will be grouped vesicles which are going to rupture, and of course these vesicles are painful. They will rupture and form polycyclic erosions, which are again painful. Polycyclic erosions which are painful, and this is associated with bilateral painful lymphadenopathy. Painful lymphadenopathy. But here remember, bubo will be absent. Bubo will be absent. And the last one which you are able to see is granuloma inguinal. It is also referred to as donovanosis. So in donovanosis, what will be the presentation? Genital ulcer is described as beefy red ulcer. Beefy red ulcer, and along with that, the lymphadenopathy is going to be absent. So here there is going to be only subcutaneous swelling in the inguinal lymph node area. So this is referred to as pseudobubo. This is what is referred to as pseudobubo. So I hope you can now easily diagnose these conditions. And if you look, the two genital ulcer diseases which are painful are chancroid and herpes. So both these are going to produce painful genital ulcers. Very, very important. Painful genital ulcers. So this is the next question. Which of the following is associated with the clinical condition shown in the image? And in the image, if you observe very, very carefully, what you are able to notice, that a child is there who is having this hyperpigmentation, which is present, not only affecting one side, but it is also present on the other side, right side. Left side is mainly having the lesion, but also there is no midline demarcation, and this lesion is also encroaching onto the right side. And you are able to see on this image that there is also presence of hairs. So a child who is having this kind of hyperpigmented lesion associated with hypertrichosis, which is present both the sides, you should always think about CMN, which stands for congenital melanocytic nevus, which stands for congenital melanocytic nevus. And please remember, there is a entity called as giant CMN, in which there is a chance of malignant melanoma transformation. So the answer here is option C. Please remember few characteristics of the CMN. It is seen since birth. Why? Because it is a congenital, and there is going to be a black colored lesion which is going to have increased hair growth, hypertrichosis. And of course, giant congenital melanocytic nevus is going to have a risk of transformation into melanoma. Very, very, very important. So this is another image where you are able to see that a child is having this very, very well defined margined CMN lesion associated with hypertrichosis. And this is yet another image where you are able to see the giant nature, where it is more than 20 centimeters in size, and you are able to see that it is crossing the midline and it is going to produce lesions bilaterally. So there is one entity which is called as Becker's nevus, which looks same. There is going to be pigmentation and increased hair growth. But how can I differentiate? In Becker's nevus, please remember, the lesions are going to be seen at the time of puberty. So it is a acquired nevus. It is acquired nevus. and the lesions are going to be present only on one side because it is a unilateral condition. Okay, and the pigmentation is going to be brown pigmentation, brownish pigmentation. And apart from that, yes, even in Becker's nevus there is going to be increased hair growth. So if you observe, the first two points are going to help differentiate Becker's nevus from congenital melanocytic nevus. Okay, so this is in this particular video. Thank you so much. Happy learning. Bye bye.